Today we're going to be talking about the CorEvitas Spheres registry done in collaboration with the Guthrie Jackson Foundation about neuromyelitis optica or NMO spectrum disorders as it's currently known. This is a condition that really has been perceived as a unique disease in the last 2 decades. And we've learned quite a bit about it. But along with our learning, things have evolved. We've become better at diagnosis and have expanded the spectrum of the disease. And all of these things result in changes in how we understand the disease and a need to better characterize the disease in terms of its manifestations, its course and natural history. And this has led to a need for gaining real-world experience. And another important thing has been major changes in the way we treat this disease. We have recognized that different treatments are required than used for multiple sclerosis. And now we have a number of new treatments, and my colleague, Dr. Michael Levy, is going to talk to you a bit about those treatments. Michael?
Thank you, Brian. It is great to be here and to talk about these 3 new treatments. These were all trialed in international placebo-controlled studies that all launched around the same time in 2013, 2014. The first drug that started the trial was Eculizumab, terminal complement inhibitor that was thought to be useful in preventing the complement-mediated damage in the spinal cord that you see on the pathology of NMO tissue that's been targeted by the immune system. And this trial enrolled patients who were aquaporin 4 seropositive only, and that's different from the other 2 studies. And they also sought to enroll patients who had more active disease, 2 attacks in the past year. And they showed that Eculizumab is very effective in preventing relapses, a total reduction in the risk of about 94% compared to placebo. And the placebo group was allowed to use background therapy. The second trial that launched was Satralizumab, an IL-6 interleukin-6 receptor blocker. And they did 2 separate studies that have been for the most part, combined in terms of analysis. There was one study in the world, the outside of the United States, that used a background placebo treatment like azathioprine mycophenolate. And then there was the arm in the United States that was pure placebo. But they were still relatively similar enough that we combined the data. And if you look only at the seropositive patients in a comparison to Eculizumab, for example, the reduction in risk of relapse was somewhere around 75%, which is also very good. And then the third study to launch was Inebilizumab, a CD19 B-cell depleting drug that targeted a few more pre-B cells and a few more plasmablasts and short-lived plasma cells compared to rituximab. Rituximab we've been using off-label for a long time, so there was comfort with using another B-cell depleting drug. And this one proved to be about the same as rituximab in terms of our observation of rituximab, that about 77% risk reduction just by depleting B cells with Inebilizumab. All 3 drugs were, for the most part, safe. There were no major safety signals that we're worried about, especially compared to the risk of a relapse in NMO, which we know is devastating. And so all 3 drugs have now been approved in the United States and are seeking approval worldwide. And our patients who are newly diagnosed are, for the most part, using these new FDA approved drugs. And some of the patients who've been on rituximab or other therapies prior to their approval have been considering switching over. And so this longitudinal repository allows us to see how patients are doing on both the older drugs and the newer drugs.
Thanks. I'll jump in. I'm Leslie Harrold. I'm from the CorEvitas company. We specialize in developing these autoimmune registries and really building upon the data to inform clinical practice. So when you have patients who are part of a clinical trial. Clearly, it's a very select subset of patients, the more severe patients, and often not with a range of comorbidities. The value of real world data is that you can look at patients who you're much more commonly to see in clinical practice. They have the range of disease activity, they have a range of comorbidities. And so in that way, we can look at the natural history of the disease, the effectiveness of the medications, the safety of medications, and also better understand the patient experience. The plan is to get sites on board. We would gather data from both physicians and their patients. And then in that way, we would follow them over time to see how they are doing and be able to assess sort of more long-term how they're doing in typical clinical practice.
The idea is that this is going to be a longitudinal registry that will involve approximately 35 sites, I believe, and enroll 800 patients. Half of those patients will be on one of these new treatments that Dr. Levy talked with you about, and the other half will be on a variety of treatments. And this will allow some degree of comparison within the limits of non-controlled data. But as you've heard, there's a lot of advantages of collecting real-world data. The clinical trials assessed only a single clinical event, the time to the first attack. And of course, patients enrolled in this study will get their experience over a much longer period of time, and that will provide a lot of useful information. So there'll be both regular visits, and if patients experience relapse, the patients will be seen, and we will be piloting the use of a tool that has been developed with the Guthrie-Jackson Foundation called Relapse Navigator to enhance the confidence that a clinical event truly is a relapse. So the use of that Relapse Navigator will be integrated to capture information about relapses, but the registry will collect information on quality of life and a broad number of outcome measures that are relevant to patients with NMO, not just relapses.
And I would add, from the academic point of view, these types of data sets are really important for researchers to be able to answer questions. So this data set will be available for outside researchers who have interests in the NMO disease course and can partner with the organization to get some of that data and to analyze it, and we'll all publish together on it. And so I think that that's a really important factor for not only for each site to consider their participation, but also for patients to feel like they're contributing to the science.
Yeah, absolutely. So I'm the Chief Scientific Officer, and I direct the Epi and Biostat group. We have over 55 master's and PhD epidemiologists and biostatisticians. We work with investigators to help formulate questions, to then analyze the data, and then present it in the public domain. Our purpose is really to improve patient care and improve our understanding of the disease. And so we very much look forward to working with partners to get that knowledge out there.
I think as sites come online, there'll be more available, closer options. I think at the moment, there are about 8 to 10 sites that are currently enrolling around the United States. And so right now you do have to come in person, and there's a survey process and data collection process that's involved. And then we're hoping that the patients come back every 6 months to the same site. So ideally, it would be someplace close and accessible to the patient, and maybe even at their doctor's office.
Yeah, I think that real world data is really essential. As Leslie has pointed out, clinical trials are clearly the standard, but miss important points about patients' comorbidity and their real world experience. So gaining real world experience is helpful in part for comparison between different agents and just understanding the interaction between diverse patient factors and treatment. So I think these type of data through registries is going to be very impactful for management of patients with NMOSD.